This this last video in Unit 4, we're going to be talking about what happens during the blood donation process. So what are those donor requirements? What makes a person eligible to donate blood? And then what happens to those donated products after the donation? Okay, so the donor screening is broken into 4 phases. So you've got the registration of the donor, educational materials, health history, interview, and then a physical examination. So that screening process includes information on the donation process and potential adverse consequences of blood donation. So the donor is going to get informed and educated on anything that could go wrong, or what kind of questions they're going to be asked during the screening process. The health assessment, so that health history interview, is going to ask the donor about any risky behaviors that they may engage in, medications that they take, travel, and other factors that could have potential impact to donor or recipient safety. And then the physical exam just checks the parameters that are set for blood donation. So those usually include height, weight, and a hemoglobin or iron check before the donor is allowed to donate blood. So the donor's eligibility determines the donor's ability to donate blood and blood components. So the donor has to sign a written informed consent to allow blood to be collected and used. And the suitability of the donation means a determination of whether the donation is acceptable for transfusion or for further manufacturing use. Donor registration and donor identification. So this part of the process includes documenting information that fully identifies the donor on an individual donation registration card. So this will have access to past donation history that allows the staff to confirm that the donor information is correct, that enough time has passed since the last donation, and that the donor is not on some type of deferral status. So the donor record should include the donor's full name, a permanent address, and contact information. And the donation center is going to obtain a postal address for the donor that's good for at least 8 weeks. They're going to ask for date of birth. The donor has to be at least 16 years old. If the state considers 16-year-olds to be minors, their parental consent may be required for the donor to donate blood. Gender of the donor, and then some additional useful information, the donor's race, social security number, photo ID, intended use of the donation. For instance, is it going to be allogenic, which means that it's for the general population? Is it going to be directed, meaning that it's intended for a specific person? Is it going to be autologous, meaning that you're donating for the potential that you yourself could need that blood product? Or is it for apheresis, which is a specific component of the blood, meaning you're donating for a specific component of the blood to be pulled out and used? Okay, and then the date of last donation. So 8 weeks is what they require between whole blood donations, 16 weeks after a 2-unit red cell collection, and only certain people are eligible for a 2-unit red cell donation. It's dependent on height and weight. Have to wait at least 7 days between donation of plasma or platelet pheresis. Physical requirements of the donor. So all of these things are going to be checked before the donor is considered eligible to donate. So the donor has to be in general good health. So you can't come in, if you're feeling yucky when you come in, they're going to turn you away if you tell them that you're feeling yucky. at least 16 years of age or older, or conform to whatever the state's laws are. The male, if it's a male donor, they have to have a hemoglobin of at least 13 grams per deciliter. Females are a minimum 12.5 grams per deciliter, not to exceed 20 grams per deciliter in males or females. Hematocrit, minimum of 39% hematocrit. Females, 38% minimum hematocrit. Temperature cannot be more than 37.5 degrees Celsius or 99.5 degrees Fahrenheit. Blood pressure has to be less than 180/100. Pulse has to be between 50 to 100 beats per minute, and weight, patient or the donor has to be a minimum of 110 pounds. And they will check all of that in that kind of like pre-screening. And if the donor does not adhere to any of those parameters, then they would not be eligible to donate. And here is a chart that I found online that just kind of goes over some of that information, but it relates more specifically to the component being donated. So you can take a look at that information. Okay, so now we're going to get into donor deferrals. So if you donate, or if you go to donate blood, you're going to be asked to fill out like a health history questionnaire. And so there are parameters that are established that are related to either like disease states, risky behaviors, or other things that could potentially make the donor not eligible to donate, either temporarily or permanently, depending on what's uncovered in the history. So we're going to go through some of those different types of deferrals. So, and I will say also that a lot of this information on the deferrals can change fairly often, as we uncover new disease states or parameters around something may change. So just take that with a grain of salt, that some of these that are listed, maybe they're not temporary deferrals anymore. And you can, but for the purposes of our class and testing, go by what's in the PowerPoint right now. Okay, so temporary deferrals. So these would be recommended if the donor would be eligible at a specific time in the future. So a lot of times a temporary deferral period is 12 months. And some examples of temporary deferrals include body piercings or tattoos, which has to be, it's a 3-month deferral period if the body piercing or the tattoo was not obtained in a regulated, state-regulated facility. If it was in a state-regulated facility, then there is not a deferral anymore. There used to be no matter what, but now there's not. Medications, so it depends mainly on the condition that the medications are prescribed for. Some medications that can have a deferral period: antibiotics, anticonvulsants, anticoagulants, insulin. There's no deferral if the diabetes is well controlled, and antiarrhythmics. If the donor has received a blood transfusion, so the last donation must have been more than 3 months ago. Attenuated viral and bacterial vaccines, so there's no deferral, or up to 8 weeks depending on the vaccine. So for a COVID vaccine, there's a 2-week deferral if the vaccine was a live attenuated vaccine, or no deferral if the vaccine is a non-replicating, inactivated, or RNA-based vaccine. So you would have to, or maybe the donor facility folks would have to know that. 2 weeks deferral period for measles, mumps, TB, or yellow fever vaccine. 4 weeks for rubella, MMR, varicella. 8 weeks if vaccinated or came in contact with someone vaccinated for smallpox. Syphilis or gonorrhea is a 3-month deferral period after the completion of treatment. If a sexual partner has HCV or HBV, if the donor has multiple partners, sex with a new partner or multiple partners, or those who have engaged in anal sex in the last 3 months. Immunoglobulin for HBV, so this is given after exposure to HBV, so that's a 3-month deferral. Travel to a malaria endemic area is 3 months, or could be up to 3 years after becoming asymptomatic if the patient or if the donor was diagnosed with malaria. And then, is the donor pregnant or breastfeeding? So they can't donate while pregnant and must wait 6 weeks after the end of pregnancy. Okay, and then the next kind of category of deferrals are going to be indefinite deferral. So the donor cannot make an allogenic donation for an unspecified period because of some type of current regulatory requirement. So if the requirements change, that indefinite deferral would no longer apply. So some conditions that could lead to an indefinite deferral would be a history of babesiosis or Chagas disease, positive HBV test by NAT, repeatedly reactive tests to anti-HBV core or anti-HTLV, and a present or past clinical or lab evidence of infection with HCV, HTLV, HIV, or Trypanosoma cruzi, and then use of a needle to administer non-prescription drugs in the past 3 months. The last category of donation deferrals is permanent deferral. So this occurs from a high-risk behavior indicator or a positive test result. Any donor or any person who has been told that they're given that permanent deferral status cannot regain eligibility. So there's a medication called Tegesen, approved in 1986 to treat psoriasis, but it was later removed from the market due to risk of severe birth defects. So if the patient's ever been on Tegesen, they would have a permanent deferral status. Confirmed positive test for HBV surface antigen, reactive nucleic acid test for HCV or HIV during re-entry testing. The donor is a recipient of Duramatter or human pituitary growth hormone prior to 1985, because that indicates an increased risk of Creutzfeldt-Jakob disease. If there's any family history of Creutzfeldt-Jakob disease, and if the donor's a donor that has a history of blood cancers such as leukemia or lymphoma. Okay, so this next little section that we're going to talk about is about the blood component itself. Like once the component has been donated, how is it treated? So the blood donation sample bag labeling. So the primary bag is used for the blood collection, and then it'll have all like little satellite bags that come off of it. So all of those attached satellite bags, sample tubes, and the donor registration form require a label with a unique identification number. A single blood donation can provide transfusion therapy to multiple patients in the form of red cells, platelets, fresh frozen plasma, and cryoprecipitate. And those components can be prepared either by collecting whole blood and then transforming them into the components by centrifugation, or they can be collected by collecting those targeted components using a method called apheresis, which involves centrifugation of whole blood at the donor's bedside and returning the fractions that are not collected. So usually more of the target component that can be collected by apheresis than through whole blood collection that then later separates into the components. Okay, the collection itself. So before or after donation, 2 to 4 specimen tubes are drawn for testing donor sample for the presence of disease or infection. The last couple times that I have donated blood, they've not actually collected those specimen tubes, so it's not like you're having phlebotomy done when you're there, in addition to the blood donation, they aliquot a portion of the donation to use for that testing. They're going to apply a blood pressure cuff and inflate it to 40 to 60, which is going to make the veins more prominent. They're going to clean the area with iodophor, then 10% iodine in a circular motion from the center outward. 16 gauge needle is used and attached to the primary blood bag. And blood donation needles are pretty big, bigger than what you would have for if you were just going to the doctor to have blood drawn. The usual donation time for a unit of whole blood is 8 to 12 minutes. Now, I will say that that's just for the blood collection. So once you step into the mobile unit or into the facility, the whole procedure from start to finish, doing the education, the health history, the pre-testing, can take maybe an hour, maybe a little bit more, but the actual collection of the blood is pretty quick. Units that require greater than 15 minutes of draw time may not be suitable for the preparation of platelets, FFP, or cryo, and frequent mixing of the blood with the anticoagulant in the bag during the collection process is critical to avoid blood clots. They have manual and automated mixing devices available. And then there's a balance system or an electronic scale that monitors the volume of the blood drawn. Okay, some adverse donor reactions. So although donations are usually tolerated pretty well, there are some adverse reactions that can occur. So this chart has a summary of some of those possible reactions and treatments that should be initiated. And I'll let you read over those, but probably the most common would be, people who possibly faint or may feel like they're going to faint, which could be due to a few different reasons. And then I would say hematoma might be the second most common. Okay, donor unit processing. So the donor unit that's collected has to be tested and processed by blood bank technologists before it can be made available for transfusion. Tests that are performed on the donor unit include an ABO-RH, an antibody screen, an infectious disease screen, which includes testing for hepatitis B, hepatitis C, HIV, HTLV, West Nile virus, syphilis, trypanosoma cruzi, Zika, Ebola, and Babesia, CMV, which CMV is not done on all units, it's only a portion, and those that are negative for CMV are set aside for transfusion to immunocompromised adults or premature infants. And then also testing for bacterial contamination in apheresis platelets and platelet components. They are stored at room temperature, so that's going to provide a better environment for bacteria to grow. So we have to test for bacterial contamination. And then once the hospital or the facility receives the units from the donation facility, the only thing that we have to do to retype or to retest once we've received those units is we do a confirmation on the ABO-RH status. So the donation facility, they're going to do all of this stuff up here. When we get the blood in from the donation facility, this is all we have to confirm is that ABO-RH. And I'll let you guys look through this chart also on the patterns observed in hepatitis B. Okay, blood collection and storage. So there's going to be an anticoagulant preservative solution that works to prevent clotting, but it also extends the storage time of the red cells so that these, donor units that we've got in the blood bank, we can keep them for as long as possible. The volume of the solution in the primary collection bag is either 63 mLs or 70 mLs, and the standard whole blood collection volume is 450 mLs plus or minus 45, or 500 mLs plus or minus 50. The purpose of the preservative solutions are to minimize the effects of the biochemical changes and to maximize the shelf life of the components. Some of the most common anticoagulants that are used include citrate, phosphate dextrose, or CPD. This is usually the anticoagulant of choice. Allows for red cells to be stored for 21 days as long as they are kept refrigerated. There's less acid, there's less hemolysis, less potassium leakage than with ACD. There's also CPDA, so that's your citrate phosphate dextrose with adenine, allows the unit to be held for 35 days. AS3, dextrose adenine saline citrate, holds for 42 days. And then some of the storage effects on red cells. So over time, those stored red cells can have increased plasma hemoglobin, plasma potassium, osmotic fragility, mechanical fragility, and cytokines if the unit is not leukocyte reduced, and then decreased viable cells. So over time, those red cells are going to lose those membrane lipids, decreased plasma pH, plasma sodium, red cell ATP, 2,3-DPG, so this impairs the ability of releasing oxygen and changes the shape of the red cell from a disc to a sphere. Okay, talking a little bit about red cell component or blood component preparation. So the facility's inventory requirements, the drawing location, the storage temp that's available, and the time constraints usually are, those factors are what are going to dictate which components are collected and prepared. Centrifugation separates the blood components from the original whole blood unit. So depending on the component to be prepared, different centrifugation times and speeds can be used. To prevent bacterial contamination of a blood unit, we want to make sure that a sterile needle is used during the donation procedure, which that's the case anyway. And then there's this two-step method of cleansing the donor arm that's performed that I mentioned a few minutes ago. And then they have a diversion pouch that is utilized for units to make platelet packs. Okay, for whole blood, so we're going to talk about some red cell component parts now. So whole blood is the unmodified component which consists of red cells, white cells, platelets, and plasma proteins with the anticoagulant preservative solution. So we're going to use whole blood to treat actively bleeding patients who have lost more than 25% of their blood volume. This helps by limiting multiple donor exposures. So you can treat a patient that's lost a lot of blood with one component, with one product, versus treating them with red cells and then treating them with plasma and then treating them with platelets, which would all be from different donors. Whole blood increases hemoglobin by about 1 gram per deciliter and the hematocrit by about 3%. Has to be ABO identical to the recipient. It has to be cross-matched before administration. The exception to that is the use of Group O low titer whole blood in the cases of traumatic injury. So that would be your emergency release. When stored at refrigerated temperature between 1 to 6 degrees Celsius, it's stable for 21 days with CPD, 35 days with CPDA 1, and then 42 days with CPDAS. Okay, next, your packed red cells. So this is the red cells that contain hemoglobin, which transports oxygen through the bloodstream into the tissues. So red cells increase the mass of circulating red cells in situations where tissue oxygenation may be impaired by acute or chronic blood loss. So that could be either through hemorrhage or anemia. Some patients who might commonly require red cell transfusions include oncology patients that are undergoing chemotherapy or radiation, trauma patients, patients undergoing cardiac, orthopedic, or other surgeries, patients with end-stage renal disease, premature infants and neonates, patients with sickle cell disease. And just like with whole blood, transfusing 1 unit of red cells usually is going to increase the hemoglobin by about 1 gram per deciliter or the hematocrit by 3%. When stored at 1 to 6 degrees Celsius, packed red cells are stable at 21 days with CPD, 35 days with CPDA, 42 with CPDAS. And when those units are received in your lab from the donor facility, we have to confirm that ABO and RH negative status for all units. If the unit is intended for autologous donation, so remember that's a unit that a patient has donated for themselves, the ABO RH still has to be confirmed before transfusion. There's a picture of units of packed red cells that you might see in the blood bank. Okay, leukocyte reduced red cells. So white cells remaining in red cell units are associated with adverse transfusion reactions and immunization to leukocyte antigens. So reduction in those white cells before the red cells are stored is optimal because it reduces the leukocyte fragments and cytokines that increase during the storage period. So this helps prevent transfusion reactions, and it reduces the danger of transfusion transmitted CMV because the virus resides in the cytoplasm of white cells. But this does not prevent graft versus host disease. Use of leukocyte-reduced red cells has become standard practice in most hospitals, and it's prepared with a method that's known to retain at least 85% of the original red cells and reduce the white cell number in the final components to less than 5 times 10 to the 6th in each unit. Okay, frozen red cells. So these are used for long-term preservation for maintenance of inventory of rare units or to extend the availability of autologous units. This method of freezing red cell donations can extend the storage time up to 10 years from the collection if it's stored at or below negative 65 degrees Celsius. So this is going to be the longest storage time of all of the components. The unit should be frozen within 6 days of collection. Glycerol gets added as a cryoprotective agent to prevent the red cells from dehydrating, and it also helps prevent formation of ice crystals, which can cause hemolysis. The glycerol gets added slowly until the final glycerol concentration of 40% weight per volume is achieved, and then it's transferred to a polyolefin or polyvinyl chloride bag and placed in a metal or cardboard canister to prevent breakage at low temperatures. Freezing can also be accomplished with a lower glycerol concentration if a liquid nitrogen freezer is used. So in this method, the glycerol concentration is about 20%, and the initial freezing temperature is negative 196 Celsius. Then the storage temp is maintained at negative 120. Frozen red cells are thawed, and the glycerol is removed by the process of deglycerolization before the unit can be issued to a recipient. So that process is usually performed on an instrument called a blood cell processor, which gradually adds preset saline volumes, mixes and centrifuges the cell, and it removes that supernatant automatically. So the unit is washed in a series of saline solutions of decreasing osmolarity. The saline solutions of 12%, and then 1.6%, and then 0.9%, and then normal saline with 0.2% dextrose are used, and those wash solutions help to draw the glycerol out of the cells. Because that process of deglycerolization involves entering the blood unit, the system is now considered open. So the product has to be transfused within 24 hours, and then once it's thawed and deglycerolized, it has to be stored at 4 degrees Celsius until it can be transfused. Okay, washed red cells. These are useful for patients reacting to the small amount of plasma proteins that can remain in a unit of red cells. reactions can be allergic, febrile, or anaphylactic. So a patient with an IgA deficiency and clinically significant anti-A requires washed red cells for transfusion. These also get used in intrauterine or neonate transfusions. The washing process is accomplished with approximately 1 to 2,000 mLs of 0.9% saline, using that automatic blood cell processor that is used for the deglycerylation. And this is associated with the loss of up to 20% of the original red cells, and it's not an effective method of removing white cells. Washed red cells are then stored at 1 to 6 degrees Celsius for up to 24 hours. Okay, irradiated red cells, which we mentioned briefly earlier. So you've got viable T-lymphs in cellular blood components that can cause transfusion-associated graft versus host disease, which is fatal in more than 90% of affected patients. So gamma irradiation of cellular blood components prevents that proliferation of the donor's T-lymphs that cause transfusion-associated graft versus host disease. Radiation reduces red cell membrane damage that causes red cell units to have a higher plasma of potassium. And the expiration date of irradiated red cells is changed to 28 days after irradiation if the available shelf life exceeds 28 days. And then you want to irradiate the units just prior to use, so it destroys T cells. And again, irradiated cells are used largely for immunocompromised patients. Okay, different platelet components. So these get prepared from whole blood. They're going to contain at least 5.5 times 10 to the 10 platelets per unit and should elevate the patient's platelet count by 5 to 10,000 microliters in a patient weighing 70 kilograms. Platelets are essential for hemostasis. Platelets that are prepared from a unit of whole blood with a light spin, they should not be cooled to less than 20 degrees Celsius, and platelets have to be harvested within 8 hours. Once they're prepared, the platelets then have a 5-day shelf life and have to be constantly agitated and kept at room temperature. So if you keep platelets in your lab, you're going to have a platelet agitator, which is not as aggressive as it seems or as it sounds. It's just like a little bench that kind of rotates or gently rocks the platelets. So functions of the platelets include maintenance of vascular integrity, initial arrest of bleeding by formation of a platelet plug, stabilization of the hemostatic plug by contributing to the process of fibrin formation. And platelets are transfused to control or prevent bleeding associated with critically decreased circulating platelet numbers or functionally abnormal platelets. So it's not going to help with platelet destruction due to some type of autoimmune disorder, because your body's just going to keep destroying those platelets. Some patient populations that might require platelet transfusions: cancer patients undergoing chemo or radiation therapy, recipients of hematopoietic progenitor cell transplants for a period after the transplant, patients with post-operative bleeding, or organ transplant patients. For patients needing platelets, frequent transfusion a lot of times is necessary due to the short lifespan of the platelets in circulation. It's only about 3 to 4 days. And some patients experience what is referred to as platelet refractory state, where they are unresponsive to platelet transfusions. So that could be due to a patient antibody to HLA antigens, platelet autoantibodies, and then there are some other non-immune causes as well. Pooled platelets. So in order to achieve a therapeutic dose, platelet concentrates are going to be pooled for transfusions in adults. An approximate dose is 1 unit per kilogram of patient body weight, which yields pools of 6 to 10 platelets. So this platelet pooling method creates an open system, which changes that expiration from 4 hours from the start of pooling. Pooled platelets should be stored at room temperature with constant gentle agitation until they're transfused. They can also be pooled using a commercial pre-storage pooling bag that maintains an expiration date of the oldest component in the pool. So that can be up to 5 days with that agitation at room temperature, pH of 6. Donating by plasmapheresis has an advantage of being able to donate 2 times per week over donating whole blood that's prepared into a platelet product. Okay, and then plasma components. So we've got fresh frozen plasma. So FFP contains all the coag factors, including the labile factors 5 and H, which do not store well at temperatures over -18. Whole blood is centrifuged with a light spin to separate red cells from plasma and has to be prepared within 8 hours of collection, and then it has to be stored at -18 degrees for up to 1 year. It has to be thawed before it's administered in a 37°C water bath for about 20 to 30 minutes with constant agitation. And that's exactly what it sounds like. It's just a water bath that's warmed to body temperature, and you place the unit of FFP into a bag, and then the water bath kind of has like this little contraption that holds the bag and dunks it into the warm water until it thaws. Or it can be thawed in an FDA-approved microwave. This procedure may require the unit to be placed in a plastic bag to limit contamination of the ports while in the water bath. And then the other reason for that is in case the FFP bag were to leak or bust during thawing. Once the unit has been thawed, it has to be transfused within 24 hours, and if it's not, the product should be relabeled as thawed plasma and stored refrigerated for up to 5 days after it's thawed. Cross-matching for FFP is not necessary, but the plasma should be ABO compatible with the patient's red cells. So FFP is indicated for management of bleeding in patients who require coag factors 2, 5, 10, or 11. If a patient has abnormal coag assays that result from massive transfusion. For management of patients anticoagulated with warfarin who are bleeding or require emergency surgery. And for a plasma transfusion, the universal donor is AB positive or negative because they don't have any antibodies in the plasma. Type O would be the universal recipient because they have both A and B antibodies. And then the RH type doesn't matter because there won't be any anti-D in the donor unit. Here's what a unit of FFP looks like, and these are actually thawed. They don't look like they're frozen. Here is that water bath that we use. So this reservoir is filled with water. It's heated and kept at about 37°C. These little things here come up, lift up out of the water bath, and you attach the unit to a little hook that's on that there, and then it just kind of gently lifts the unit up and down in that water bath until it thaws. Here is a chart showing FFP compatibility. So if the recipient is type A, they can receive type A or type AB, and you can look at the rest of that. Okay, cryoprecipitant or antihemophilic factor is a cold, insoluble precipitate formed when a unit of FFP is thawed at between 1 to 6°C. And then that cryo is collected by centrifugation after the FFP is thawed. It contains in a concentrated form most of the coag factors that are found in FFP. So that includes your von Willebrand factors, which is needed for platelet adhesion to damaged epithelium. It contains fibrinogen, which is cleaved into fibrin in the presence of thrombin to form a clot. It contains factor VIII, which is a procoagulant that is deficient in hemophilia A. It contains fibronectin, which is a large glycoprotein that provides cell adhesion. And then factor 12, which is a coag protein at the start of coag's intrinsic pathway. So once the cryo is separated from the FFP, it's frozen within 1 hour of preparation, and it is stored at negative 18 degrees Celsius or colder for up to 1 year from the date of collection. The white precipitate that you see in thawed FFP, that is cryoprecipitate. The primary clinical use for cryo is a supplement for patients with deficiencies of factor 13 and fibrinogen, and pooled cryo should have a minimum of 150 milligrams of fibrinogen and 80 international units of factor 8 times the number of components in the pool. So 150 milligrams of fibrinogen and 80 international units of factor 8 per unit pooled. And here's a picture of cryoprecipitate, so it really looks like FFP. Okay, so that is the end of Unit 4. And in the next unit, we're going to talk about, I think we go into more, it kind of relates back to Unit 1 a lot with immunology and testing that we do for it.